This podcast was produced by OAR FM Dunedin with support from New Zealand On Air.
Ever wondered what it's like to go through life having no childhood, with a brain that has almost completely rewired itself? In this podcast series, I will explore some of the ways adults with childhood traumatic brain injuries experience life through a unique lens, and what makes them so magically distinct in this world of ours. I'm Leanne Barnett. Welcome to Headstrong, a life with traumatic brain injury. Today we are lucky to have an amazing neuropsychiatrist who happens to be one of the top in the country, if not the top in the country, on the area of adults with childhood traumatic brain injuries. His name is Greg Finucane. So, hello, Dr. Finucane. How's things going up in Auckland?
Hi, Leanne. Not bad. Another cloudy day. There we are.
At least we've got warmth today then. Right. Tell us about what drew you into neuropsychiatry, in particular into wanting to work with adults with childhood traumatic brain injuries.
Probably ended up doing it accidentally rather than necessarily going towards it. I ended up doing quite a lot of liaison psychiatry as part of my training and had the opportunity to work with Dorothy Gronwell and Philip Wrightson in the concussion clinic in Auckland. So the first sort of such clinic around the place, really. And got on with them, and so they got me seeing lots of patients and all that kind of thing. And then inevitably, given the New Zealand situation, you end up doing a bit of ACC work. So I started running into people who had very early brain injuries that sort of nobody had sorted out. And I guess part of the history of all of this is nobody was really doing pediatric brain injury work about 20 years ago. There are more people involved in the area now, but once upon a time, there was no pediatric equivalent of the concussion clinic. And so there was a need, I guess. So probably the short answer.
Can you tell us in general terms what makes an adult with a brain injury that they sustained during childhood different to someone who you work with who has sustained a brain injury as an adult? Like, are the common traits within that group, like behavioural presentations or impairments and disabilities that my group display that show us as being different that you have encountered?
Yeah, look, I think the big picture thing is that, adults, let's say over the age of 21 or 22, so sort of edging out of adolescence, their personality is kind of fairly fully formed by that age. They've got a bit of life experience. They're turning into who they are. And so there's something that they like, which then gets disrupted. The problem with very early injuries is that development gets skewed. And then people get very confused about whether that's just them or whether that's the consequences of the brain injury. So it's easy with adults to tell what's them, previously, and what effect the brain injury has had. That's much more complicated and people have had an early brain injury. And so I think that's why the needs have been ignored for a while, is there's been an assumption that they're just like that. There was another assumption 20 years ago that I think is held less strongly now, which was that the brain in childhood is very plastic and that if the brain is injured, it mostly can rewire itself, so it's not a problem. So there was kind of an assumption for a long time that you were going to be fine, just get on with it and go into learning environments and you'll still learn and all that kind of thing. Instead of this more subtle, diffuse kind of set of problems that are more difficult to kind of visualize, if you like, more difficult to get a grip on. But they're certainly there.
Mm. When you talk about the old story, which I've heard,
yes.
of the brain rewiring itself, you'll be fine.
Yes.
I'd say the brain does rewire itself, but it rewires itself with difficulties. Would I be correct?
Oh, look, absolutely. And this, we probably don't want to go too far into this kind of territory, but the whole issue of neuroplasticity becomes slightly fraught. So there are some people recovering from injuries that we think probably have a form of negative neuroplasticity. They're wire and symptoms rather than sort of the wires going back in the same place. Does that make sense?
Yes.
And so for that to happen in childhood, again, it's a much more wide-ranging and sort of difficult to pin down kind of change in the falling off the developmental curve in various kinds of ways.
Fantastic. Within your work, what have you found most effective supporting the me's of this world? Those of us who are way down the track, 40 years on from a brain injury, and
I might think this because I'm a clinical neuropsychiatrist, but I always think that data is good. And if the data helps you pin down specific problems that you can address, then that's good too. And so looking for symptom complexes like, say, ADHD, which I think we're going to talk about, or, for example, secondary autism spectrum disorder or other kinds of problems, it's worth looking for them, because if you don't look for them, you might not find them. And if you don't find them, you're not going to be addressing them.
Okay, yep. I want to talk about the research in the area. It's an area like I was aware before I started this podcast series that there was very little research around adults with childhood traumatic brain injuries. And when I went to try and find it, it became blatantly apparent how little there was. So why is there a lack of research in the area? And how does that constrain or limit your ability to be able to provide the best support and care that you want to provide?
Yeah, well, I think those early assumptions and, for example, the lack of pediatric brain injury clinics 20 years ago meant that we don't have good cohorts following people for a long time. There's a recent paper by a guy called Jeffrey Max, who was one of the early people in the area and doing research in California about 25 years ago, who's tried to look back at some of the patients that enrolled in early studies and followed them forward. But there's very little of that kind of thing, simply because people weren't identifying cases long enough ago to collect data over a long period and see what happened. So that's the key problem, I think. Pediatric brain injury cases weren't adequately identified and so couldn't be lumped together for decent longitudinal research.
Does that limit, because you don't have, like you said, data, does that limit your ability to be able to provide adequate?
I think that's right. So if you compare, say, groups of individuals with various pediatric problems, like, say, epilepsy, let's take epilepsy as an example, there's good data on what happens to people over the decades, how they progress, what happens in terms of, negative life experiences and lack of access to care and social deprivation, all that kind of stuff. Mm-hmm. We know what happens to those people because those cohorts were defined early enough. And we don't really have that in relation to adults who've survived pediatric brain injury. And therefore, we don't actually know whether they respond to the same treatments, whether they have the same needs as people with the same clinical problems not caused by pediatric brain injury.
I haven't put this down as one of the questions that I'd written down, but I'm going to throw it at you. Tell me if you don't want to answer it.
Yeah. No, that's right.
Do you have anything you can tell us about, because I've really struggled to find anyone who can help me flesh out this idea, this understanding of how someone who loses autobiographical memory for a significant period of their childhood and how that impacts them as they're growing up. Do you have anything you can tell us about that impact, or is that outside of your scope of knowing?
Yes. I'm not sure there's much on that. That's certainly outside my scope of knowing, but I haven't seen, that would almost take a narrative approach to research, wouldn't it? And I haven't seen anything on that specifically. Yeah, so the effect of prolonged amnesia due to brain injury, not due to dissociation and trauma, psychological trauma, all that kind of thing.
Yeah, severe retrograde.
What effect does that have? I think it's very difficult to know. I haven't seen any research on that.
Which makes perfect sense as to why I haven't found any.
Yeah. I mean, one would, of course, expect it to cause issues with forming your identity through later childhood, adolescence. Adolescents have to sort of react against what they know about what people were doing all of their life anyway and all that kind of thing. You can't really do that very effectively if you can't remember it. And so the kind of developmental tasks, difficult to do them. Yeah.
It is incredibly difficult. Within this section, the last things I want to ask is, from your perspective, what needs to happen to improve things within this area, and go as wide and as broad as you need, as you want to.
So the problem related to what we were just talking about, the problem is that ACC, who are expected to provide services for, or fund services for individuals who are adults who have had pediatric brain injury due to accidents, which is a lot of them, don't have a mandate to create services. So there aren't services, that's the problem.
Really?
So, ACC don't need to help with service development. They don't need to ensure that a particular clinic environment is present. And the problem is you can't train up specialists in this sort of area unless you've got cases for them to work on. Do you know what I mean? Somebody can't become a surgeon without doing a lot of taking out. You'd want them to take at least 100 appendixes before they got to your one, right?
Yeah.
And yet we can't sort of create that with adults with pediatric brain injury. So where do the expert clinicians who are going to help people, where do they get their knowledge from? Well, they might read a few things. That's not very helpful, really.
No, they don't. So you think ACC could play a bigger part in terms of developing more focused?
I think that's right. I mean, I think they could be supporting a group of clinicians to be doing more work in this area, and then those clinicians could get the confidence of the people they're there to serve.
I always debate this with various people that over the decades have come in to support me. ACC talk about my rehabilitation. For me, I'm never going to be fully rehabilitated. I talk about habilitation. Can you describe to people what the difference is for someone to look at rehabilitation versus habilitation?
Yeah, well, that's kind of where we started today, wasn't it? That adults who have an injury have rehabilitation to get them back to kind of pretty much or close to or similar to where they started, that they recover back to where they were at. With pediatric injuries, that isn't going to happen. Development is skewed. There isn't anything it was like to be an adult before your injury. And so it has to be a more creative kind of process in a certain sort of way. It takes a lot of nuance, and people's own goals have to come into it with adult rehabilitation, but it's even more important with creating something out of, what you've got when you're a survivor of pediatric injury like that.
Fantastic. Next, I want to go on to looking at secondary ADHD within brain injuries.
Sure.
First and foremost, what is secondary ADHD versus ADHD?
Yeah, so I guess if we call the other form of ADHD primary ADHD, and then we'd be thinking of that as largely familial. 75% of the causality for most ADHD that's not related to injury of some kind is due to the genetics. And the genetics is complex. There are a small range of conditions in which, a gene or a couple of genes cause the problem, but most of it's due to a whole pile of very small variations between a whole lot of genes. And so secondary ADHD, though, by implication, is due to some particular causal factor that wasn't going to play out in the genetics. Now, of course, there's overlap between the two. It takes less of, let's say, traumatic brain injury at a particular kind of age to create ADHD if you already had a bit more disposition for it, whether or not that was going to be demonstrated in due course and the person was going to end up with ADHD. But anyway, so secondary ADHD is ADHD due to something that goes wrong. And so what can go wrong? Well, a wide range of things can go wrong, can't they? So it's not just traumatic brain injury. There's lead poisoning in childhood. A lot of people with epilepsy end up having ADHD. So that's about presumably some combined genetics, some effect of seizures on the developing brain, that kind of thing. So at least a third of people with epilepsy develop ADHD. There's prematurity, if people are a couple of months premature, that's a pretty strong risk factor. There's substances, so sodium valproate taken for your mum's epilepsy during the pregnancy can create a pretty high risk of ADHD, around 50%. Alcohol, so you know about the fetal alcohol spectrum disorder and people who end up very, very impulsive behaviours and very vulnerable and end up in jail when they didn't do anything wrong because they were easy to push into the firing line, all of that kind of thing. So there are a lot of causes of secondary ADHD, but certainly pediatric traumatic brain injury is a strong contender there.
So when I came to see you in 2022, I know that I was sent for a mental assessment to determine whether or not my depression was related to my brain injury. As I was sitting with you that day, it felt very strange. I was going through various tests that I had never taken in my life. Did you already have a strong indication looking at my notes that nigh on 40 years down the track that I may have had ADHD, secondary ADHD?
Yeah, look, not necessarily, but I guess I'm always thinking about that sort of possibility in the setting of remote, TBI. I've just seen too many patients, just so often there. There's a bit of research from 2018 which seems to show it's small. These are all small sample sizes really, but shows that about 62% in their sample of children who had a severe TBI ended up with ADHD. And that could evolve over time. It could be sort of up to 7, 8 years later that it was developing. But even so, 62% is a pretty high proportion, isn't it?
That's huge.
So, we could say it's more likely than not, really, if your brain injury's been of a more than moderate, that you'll end up with some ADHD features, whether or not you have a full syndrome.
Right. I recall that day very clearly. Not many people can stun me silent, but you did. So with ADHD or secondary ADHD, whichever one, is there a difference across genders in presentation, diagnosis, treatment, that kind of thing?
Yeah, good question. It's really hard to tell, which aspects are an artifact of the assessment process and which differences are real. And look, frankly, I don't think this is all settled down yet. So the current approach to ADHD, utilising DSM-5 and all that sort of thing, is we think about an inattentive presentation, which I tend to think is, the bits of the iceberg underneath the waterline. It's actually hard to see when people are being inattentive. I mean, sometimes it's obvious, but mostly it's not. And so let's say a child is just sitting in the classroom, not really absorbing it, but it's not apparent, not immediately apparent. Whereas the little boy climbing on the desk and bouncing around the place and sort of, being very reactive and hyperactive, that's obvious. So that's all the stuff sitting above the waterline, which is easier to notice. And that's kind of the cliche of kind of girls being inattentive and boys being hyperactive impulsive, or combined presentation when you've got both. But what I find is that there aren't many people with ADHD who have a pure culture of one of those things. So most people have a bunch of symptoms. We stick labels on them, but it's possible to be hyperactive and impulsive without being hyperactive, if you see what I mean. So it's possible to have poor control over your spending, so significant impulsivity. It's possible to be quite chatty when you're relaxed enough. It's quite possible to be, rather fidgety, but to disguise that, etc. So
would that be
sorry.
I laugh at this. The term they seem to use these days is masking.
Yeah,
I just call it being a world-class bluff artist, learning how to hide. Is that what you're talking about? Because I'm a fidgeter, and all of those kind of. And
to some extent, yes, that's part of it. That's part of it. There's a bunch of factors that can make it hard to identify which symptoms are obvious. And in fact, it's interesting doing ADHD assessments because people sort of come along and they say, no, I'm not fidgety. And then they come back the next time when their ADHD is better treated and say, oh my God, I'm not fidgeting anymore. So the thing about a real condition, and ADHD is a real condition. It's not just manufactured or on the basis of some people ticking some boxes on some questionnaires and sort of doing a bit of statistics on what they get back. Do you know what I mean?
Yes.
It's a real condition, is that the person themselves can be wrong about aspects of it, and the people around them can be wrong about aspects of it too.
Okay.
And that just means it's real. Do you know what I mean? Just like people can be unaware of what happens during their epileptic seizure. Well, of course they're unaware of what happens, And
oh, well, we know those ones. So now my absolute, this is one that I think I asked you this recently.
Yeah.
How do you separate the difference between what secondary ADHD, the effects of what is secondary ADHD versus the cognitive impairments of a traumatic brain injury? Because people have asked me that and I haven't been able to explain it.
Well, look, it's a good question, and maybe we should make the question slightly more complicated.
Okay.
Because there's another
I like complication.
There's another condition that's talked about that bounces around in that territory as well, which used to get called sluggish cognitive tempo and now tends to be called cognitive disengagement syndrome.
I like the sluggish cognitive tempo better.
That's what it was until 2022, and then people thought, we don't like the word slug, so we'll change it to cognitive disengagement syndrome. And so there's a difference between sort of proper ADHD, a sort of slow, disengaged kind of brain, and then a brain injury brain. Yeah. So, if you get a clinical neuropsychologist on talking about what they find when they do neuropsych testing on somebody with a brain injury, well, we expect a whole range of things. And obviously, it's not cookie cutter. You can't say these 5 features distinguish that from that. So every brain was different before the brain injury. That's what I got taught. Every brain injury is different. And so you end up with a whole lot of variation. But there are some key themes. And the key themes are around attentional processes, around executive dysfunction, that kind of thing. Mm-hmm. And one thing I have to warn you about in this area is that executive dysfunction is used in different ways by different people. So when people in the ADHD community talk about executive dysfunction, what they mean is they're struggling with time management, or they're struggling with prioritizing, or things like that. Now, there's a relationship between that and what we measure in post-TBI, traumatic brain injury patients. But, we measure things in those people. And one of the things about ADHD is that there's a whole lot of different possible cognitive issues that you find when you do testing. And probably the majority of the people with ADHD, in fact, don't have obvious executive function deficits if you run the standard neuropsych test past them.
Okay.
So when they talk about executive dysfunction, it's actually a subtly different thing. Does that make sense? So there's executive dysfunction as in brain injury and attentional issues as in brain injury. One of the key differences between attentional problems in ADHD and in acquired brain injury is that in ADHD, it's kind of inconsistent. So it's difficulty staying on track in a particular kind of way. So, for example, very concrete example, if you're doing digit span, for example, I'm going to tell you 5 numbers, say them back to me. You remember this kind of stuff that you get if you're doing... Yeah. What you'll get with somebody with ADHD is they will be inconsistent in that. So they might be able to tell you 4 digits forward consistently, but then they'll miss one at 5 digits forward and only do one of them correctly, but then maybe get both of them at 6 digits forward and then miss one at 7 digits forward, etc. And then maybe get one at 8 digits forward, which doesn't make sense in terms of acquired brain injury. You expect them to get to the cliff and then fall over and be relatively consistent prior to that. But the ADHD patient isn't kind of consistent in getting there. Sometimes their attention is on track, sometimes it's not. So they're capable of attending pretty well if they hold the mouth the right way and the wind's blowing the right way, which is different to the person with acquired brain injury. So, one of the key features of ADHD then is this variability in being able to apply their attention to things, which is very difficult to deal with, right? Sometimes you're on form, sometimes you're not, and you want to pull your hair out.
Yes. Oh, yes. Yes. We know that. We know that one well.
And so, for example, if somebody who's had an acquired brain injury and attentional issues, if they're well rested and we bang on about the fatigue and all that, don't we? Have your rest breaks, all that kind of stuff. If you have your rest breaks, it ought to be fairly reliable that you can attend to something all right for half an hour or something like that. You ought to be able to do that. But that's not the case with the ADHD person. It doesn't matter how much rest they've had. They might not be able to stick on a task for half an hour.
For 10 minutes.
Yeah, whatever.
Yeah. Right.
Does that make sense?
It does. It makes perfect sense. For me, it makes sense.
Yeah, and the cognitive disengagement syndrome is a thing sort of in the middle, that if you sort of leave them alone, their brain's sort of just not doing very much and they're not very engaged. But if you going to be cruel now, if you hit them over the knuckles with a ruler, like the teachers used to do, then actually they'll be able to perform quite well for, a little bit.
Yeah.
And then they'll sink back into, idling mode.
Slug mode.
Yeah.
Slug mode. Right, but how often do you encounter people like me whose secondary ADHD gets missed for nigh on 40 years?
Look, it's, unfortunately, it's most of the time, frankly, with people, adults who had pediatric brain injury, it just never got looked for.
Is that because people didn't know about it? Why?
Yeah, okay, so several reasons, I think. I think one of the key reasons is that they're different clinical worlds, and people who know about ADHD don't work in brain injury rehabilitation and vice versa. That was kind of the key problem. But let's say 20 years ago or 40 years ago, 40 years ago, there wasn't such a thing as ADHD, very much. I mean, I'm exaggerating. And then 20 years ago, there was such a thing as ADHD, but all kids grew out of it by the time they were 18.
And it was only boys.
Magically.
And it was only boys.
Yeah, it was only boys, but they all grew out of it at 18.
Yes.
I saw somebody who had a very good evaluation early in life. So I saw this guy yesterday or the day before, and he was assessed in Sydney, and it was a very good assessment, and he took Ritalin for a while and all that kind of thing, and reasonable results. But he was told at that stage 20 years ago that he was going to grow out of it, of course. And so he just stopped medication and sort of struggled on for the last 20 years. It has come back. I did the usual kind of testing we did to see what their attention is like, and yep, it's still there,
Yeah.
But that's what they thought back then. You were just going to, again, magical faith in the ability of the brain to fix things up. And in this case, as demyelination makes the brain more efficient in adolescence, the problem's going to go away. But they didn't know the problem was going to go away. They just crossed their fingers and thought it might happen.
So I guess that kind of half by tells us what the consequences are.
Yes, that's right. That's right.
Yeah.
So does that answer the question? So
yeah, no, it does.
Sort of what I've said is, nobody with ADHD was thought to have problems as an adult, and so let alone anybody with a pediatric brain trauma, because the people treating them didn't know anything about ADHD anyway.
From what I've taken from what you've said is that we've been left to struggle along on our own without adequate therapies, supports.
Yes, it's been a pretty invisible kind of problem.
Yeah.
Yeah, even more invisible than the standard invisible brain injury problem.
Yes, yeah. And for me personally, I've noticed since I got the diagnosis, the medication, and the therapy from when I first saw you, my life has changed dramatically. My brain has slowed down. Nothing's perfect, but I'm able to do a lot more than I have ever been able to do, which speaks volumes about what my potential may have been had 20 years ago.
That's right, and so that speaks to the unmet clinical need.
Yes.
This is the old problem that medical science has got better and better at keeping people alive, and hasn't done much about what we do with them after after we keep them alive.
Yeah, right. So the next question I have on my list. Around the country, it's been well publicised the difficulties people are having, adults in particular, in getting diagnosed. And is there a difference first between what is available in different parts of the country, and what is your advice to the average listener out there who suspects they may fall within those categories, and how to get around it with the current issues we face?
Well, as you know, there are variances around the country with all forms of access to healthcare and all kinds of healthcare. this is one area in which different parts of the country don't talk to each other very well. And that could probably be improved if there was some kind of Ministry of Health mandate to ensure that assessments were available for people.
Right.
Now there isn't, of course. So if you look through all the service contracts for all kinds of things with Te Whatu Ora, etc., what you find is that there are good contracts to make sure that if you have a child born and it's blue and its heart needs replumbing in Invercargill, they will be seen by somebody and they will get to have their operation in a good period of time and then get good support afterwards, etc. That's sort of well sorted out. There's no sort of formal centralised plan to ensure that ADHD assessments are available for people. So that's how it is. If you don't plan for something, you'll get what you plan for. And that's the situation we're in. And then training is fairly haphazard. And, one of my concerns is that the diagnosis of ADHD shouldn't simply be made on the basis of self-report and reading a whole lot of stuff and then go along and seeing somebody and saying, I've got all these symptoms. And the person saying, rightio, let's put you on medication then,
That's pretty scary.
So, yeah, that's right. And yet at the same time, having a day's worth of neuropsych testing to see if you've got ADHD is also, way overkill. So how do you have something sensible in the middle in which it's not simply somebody's putting up their hand and say, I'll have Ritalin, please. And at the other end, it's not making people jump through some very expensive hoops in order to get a diagnosis and treatment.
Yeah.
But it means some kind of consensus will need to be developed. And that takes central guidance from something like the Ministry of Health. And that's not there really. There are guidelines and things about, what it would be nice if people did, but without any actual leadership or whatever, that's not going to happen.
So what do you advise people to if they've got the money to go and get their own assessments?
Well, yeah, they should talk to their GP about it. GPs are more switched on than they used to be.
Yeah.
And quite rightly, though, GPs are saying, look, it's, this diagnosis is above my pay grade. So this is part of the problem. If ADHD is a neurodevelopmental disorder, if secondary ADHD is an outcome from brain injury, well, that's not nothing, is it, in terms of what you need to do to assess that clinical condition. And so you need a robust diagnosis. Once you've made the diagnosis, then fine, other people can do a lot of work with it, etc. But the diagnostic process has to be a reasonable one, just like it would be for, say, autism spectrum disorder. It's not just saying, I don't like you very much and you seem a bit cold to me and I'm sure you don't relate to people very well. That's not autism spectrum disorder,
Yeah. Know that well. Yeah.
Yeah.
Just getting towards the end, I take it the research looking at secondary ADHD for adults with childhood traumatic brain injuries is pretty thin on the ground as well?
Yes, it's mostly case reports and small case series, which, does show that medication can help, etc. But it's not the sort of robust database that there is for, let's call it primary ADHD.
Got any ideas about how we can get people to want to research these areas more?
Yeah.
I've stumped you.
Yeah, and the reason I'm stumped is I'm a bit frustrated about this particular one. I'm not going to spend my time complaining, but I have to say there doesn't seem very much interest. So just like most of the ACC-related or ACC-funded care for adults with pediatric brain injury happens outside of the public system,
Yeah.
And so most of the ADHD diagnosis and care and all that kind of thing happens outside the public system as well. And for some reason, the universities, etc., don't really have any way of networking with private practitioners to get research opportunities up and running in the right kind of way.
Seems
and I have to say, I find this intensely frustrating. Between me and my nurse practitioner, we would see 10 new patients with ADHD a week.
Wow.
If you look at the volume after 6 months, after a year, that's a lot of data you could be collecting.
Yes.
And yet there actually doesn't seem to be any interest in academia. You'd think it'd be sexy. Do you know what I mean? You'd think you'd get funding for it.
Well, it just seems short-sighted not to take advantage of it.
Yeah.
So, right, final one.
So there'll be some PhD candidates out there come and talk to practitioners in the area. Come and, we've got good cohorts,
Look up Greg online. He'll send you in the right direction. The final question, and this is a quick one. What resources are out there for those online, etc., who have secondary ADHD that you would advise for people to go to?
I think if you're an adult having survived pediatric brain injury and you think you have ADHD symptoms, then it would be good to get a diagnosis to clarify that. And then, look, a lot of the resources out there which are building up rapidly for primary ADHD, a lot of the resources are very, very good. And there's a lot of consumer experience in there. Not everybody's the same, so you have to, pick the bits that work for you, don't pick the bits that don't. But in terms of blogs, podcasts, particularly for women with ADHD, lots of advice about how to get a good daily schedule running and how to remind yourself of what to do and keep yourself functioning at your optimal, etc. There's a lot of really good stuff out there that is clearly also applicable to people with secondary ADHD.
You sent me to Attitude, ADD-tude.
Yeah, that's one of the excellent websites, yeah.
.com, isn't it?
Yeah.
AttitudeMag.com.
Yeah.
Hey, look, Greg, you are an amazing wealth of knowledge and everything. Thank you.
And thank you, Leanne. You're doing a great job for people who are, frankly, underserved in this area, and it's not good enough, really.
I hear you. You've been listening to Headstrong, a life with traumatic brain injury. In the final episode, I will speak with Dr. Bridget Murphy-Veitch from the Donald Beasley Institute about research within the field. If you'd like to listen again or hear other episodes of Headstrong, you'll find it at oar.org.nz or your favourite podcast platform. Thanks to Brain Injury New Zealand, Paula Schonfeld, and especially OAR FM for making this series possible.
This podcast was produced by OAR FM Dunedin with support from New Zealand On Air.